Great. Good afternoon, everyone. A very warm welcome to you all to this cafe on understanding the hormonal changes we go through at perimenopause and menopause and the effect they have on our heart health. As you know, February is Heart Health Awareness Month, and that's why we've chosen this topic to discuss. It's an extremely important topic individually, both heart health and menopause, and together, of course, is the height of my interest in all of this. Why we're talking about it and why we have a month dedicated to raising awareness about this topic is because heart disease is, first of all, very common, and it's the #1 cause of death in women worldwide. In the UK, I think it's dementia or Alzheimer's is the #1 cause of death, but even in the UK is one of the top 3 causes of death, also in men. So it's really important to talk about it. And of course, the relevant menopause changes that happens, the hormonal changes that happens during menopause and perimenopause, they do have a significant impact on our cardiovascular health and risk of developing cardiovascular disease in the future. But of course, the good news is that, if we know about this and we step in early enough and we do all the right things, and some of them we're in control of course, is like some of the lifestyle changes that we can modify at this point, we can reduce that risk or even prevent it happening, which is great. And that's why we want to have that knowledge to get control of our heart health at menopause, stay informed, take action, and really prioritize our well-being. So now, just looking at menopause, of course, that's when our menstrual cycles have stopped for 12 consecutive months and our ovaries are not producing the female sex hormones of estrogen, progesterone, and testosterone. Each one of these hormones, it has an impact on our cardiovascular or heart health, and together the balance of them also has an impact on it. So it's really important to start by saying that. And these hormones play a protective role in our heart health. So if we look at men and women before the woman reaches the menopause, usually they have a better cardiovascular health. So their blood pressure is usually lower, they have a better cholesterol profile to a male of their similar age group. But once a woman reaches menopause, that protective mechanism sort of diminishes and they're in par with one another as regards to their heart health. So reducing the risk, of course, at perimenopause and menopause reduces the risk of developing some of these heart conditions in the future decades. I'm going to look at individual hormones now and try to simply help you understand what these individual hormones do to our heart. So estrogen supports our blood vessels. The endothelium is the innermost part of our blood vessels. And what estrogen does, it increases the production of a gas called nitric oxide. Nitric oxide is a vasodilator. It increases the caliber or the girth of the blood vessel, and it helps it be elastic. So it's quite bouncy and it can dilate, and that reduces the blood pressure. It also helps to regulate our cholesterol. As you may know, there are different types of cholesterols. There's LDL, or the bad cholesterol that can clog up the arteries, and HDL is the good cholesterol that can protect our heart. Estrogen, liver as well is a very important organ in regulation of our cholesterol, because it sort of mops up all the bad cholesterol and pushes it out of our body. And what estrogen does, it upregulates the LDL receptors, the bad cholesterol receptors on our liver cells, and it helps it to start clearing the LDL from our bloodstream more faster and more effectively. It also increases the production of HDL, the good cholesterol that helps protect our heart. The other thing that happens when our estrogen levels start to fall is our normal sinus rhythm of our heart goes out, and some people can start getting either atrial fibrillation, which is just irregular heartbeat, and more regularly they can have palpitations or too rapid heartbeat. Estrogen and progesterone, actually, they're anti-inflammatory hormones, so they reduce the inflammation. And inflammation, as you may know, is the root cause of a lot of chronic diseases, including cardiovascular disease or heart disease, because it's that initial inflammation that happens in the blood vessels or in the cells that actually starts, it's sort of the building block of plaque formation and the clogging of the arteries that can result in things like heart attacks and strokes. Now, progesterone is a little bit more, sorry, I think I'm going backwards here. Great. Now, progesterone is a little bit more complicated than estrogen because we don't have enough research on it. So people are still doing a lot of research on progesterone to find out exactly what it does to our heart. And that's why on this slide, I've put some references in case you want to read a little bit more about this to see what the more significant or more recent research has been on. But when I talk about progesterone, this is natural progesterone or biologically identical progesterone. Of course, there's artificial progestins as well that work very differently to this. But when we talk about natural progesterone, it, again, like estrogen, it protects the blood vessel function, so that elasticity and the caliber of the blood vessel, and it helps to regulate blood pressure. So it's not just estrogen on its own, but it's when you have the estrogen and progesterone in a good balance, and both, of course, natural hormones, that is, you get the best result as regards to the heart health protection. And some of the studies have indicated that that progesterone can improve the endothelium, the innermost part of the vessel, the function of that, which is, of course, really important in reducing our heart disease in the future. Now, as I said, there is a huge difference between how natural progesterone works and the function of that as regards to our heart as opposed to the synthetic progestins. Because before, years ago, we only had access to synthetic progestins. And in fact, if a woman had heart disease, that was a huge risk factor for taking HRT, and she used to be told not to take it because synthetic progestins increase the stiffness of the blood vessels and increase the blood pressure, as well as increasing the likelihood of plaque formation. So they were told not to take it. But of course, we now have access to biologically identical progesterones, which actually has the opposite effect to this. But there's still quite a lot of work to be done on this. So it's still work in progress on progesterone. I haven't put a slide here on testosterone, but I think I just want to pause and talk about testosterone very briefly, because it is often it is thought to be a male hormone, and of course males have a lot more of testosterone, but it is an important hormone in females, and it has a number of functions, especially the support of cognition and muscle tone, metabolism, but also in heart health it plays a role, and it actually plays a supportive role and it should be balanced out with estrogen. So it improves it reduces the inflammation when it's given at the right quantity and when it's introduced at the right time. So often you may have seen that you're started on estrogen progesterone first, and then you have blood tests, and your healthcare provider may then start you on testosterone. Often they don't start testosterone at the same time as estrogen and progesterone, because the balance needs to be there first before they introduce that. So just going through what these hormones can do at different parts of our cardiovascular system. So with the blood pressure, the loss in estrogen level leads to increased stiffness in our arteries and vessels, and that pushes the blood pressure up. And we do see a much higher incidence of high blood pressure in women during menopause. With looking at cholesterol, it increases the LDL or the bad cholesterol, reduces HDL or good cholesterol. And I see this quite regularly, actually, in my clinics, that women complain that they always had really good cholesterol, and then on their last doctor visit or last time their bloods were checked, they've been told that they have a raise and they want to be started on statins. It is a good idea to, if you're going ahead with HRT or thinking about HRT, it's a really good idea to start that first, recheck the cholesterol level, because in a lot of cases I've seen that it actually helps to put it back in good levels, and the woman then doesn't need to really take statins. And of course, there's a rise in number of cases of palpitations or rapid heartbeat, as well as irregular rhythms like atrial fibrillation. Fat distribution is an independent risk factor for our cardiovascular health. So increase in belly fat or increase in midsection circumference is an independent risk factor. And unfortunately, this is one of the things that happens regardless of even the weight. So even if the weight of the person remains more or less the same as their pre-menopause, but their fat distribution or the shape of their body tends to change. There's a variety of reasons and multiple reasons why this happens. One of them is the fall in estrogen sort of increases the available testosterone, and testosterone tends to change the distribution of fat from the hips, from the arms to the belly. Also, at this time, people struggle with their sleep, they have higher cortisol level, and that can also increase the fat distribution. And as well as, of course, the fact that people are less likely, if you have multiple symptoms of menopause, like hot flushes, night sweats, aches and pains, you haven't slept enough, you're less likely to be motivated to do exercise. And of course, the hormones that regulate our appetite and our sort of sense of being full, they're also dysregulated at this point. So, and you're more likely to reach out for the simple carbohydrates, which again increases the likelihood of the belly fat increasing. So there are just a few things that can happen at this point. And, often I get asked that, can HRT help with our heart health? Now, of course, HRT is is the gold standard solution for people who don't have a particular risk factor for taking it in controlling symptoms that arise from menopause. But also, it's really important to see if a woman can benefit for starting on HRT in order to reduce her risk of developing chronic diseases in the future. One of those is heart health. And of course, the right type of HRT and starting it at the right time in this journey of menopause is crucial in improving that risk. So other conditions that it can help with would be dementia or Alzheimer's or osteoporosis and some autoimmune diseases like rheumatoid arthritis, etc. But coming back to heart health, we know that it can improve our cholesterol, maintain flexibility in our vessels, and of course reduce that risk. So if you have a genetic predisposition to heart disease, so if you have first degree relatives that have had heart attacks, atrial fibrillation, they suffer with high blood pressure, or you have familiar hypercholesterolemia, which is, just regardless of what you eat or your weight, your genetically, family-wise, your cholesterol is high, it is a good idea to see whether you can benefit from HRT in order to reduce that risk, even if you don't have any symptoms of menopause. The timing, as I said, is really important. So any sort of intervention that we do with hormone replacement therapy when it comes to management of chronic disease, it's best for it to be started as early as possible. So that's really in the perimenopause age, when the periods are still happening, maybe irregularly, but still you have them, or under the age of 60, or at least being less than 10 years post-menopause. Because once, for example, the blood vessels have stiffened up, or once the cholesterol has raised to a level that is very difficult for it to then reduce by any sort of modification or replacement of the hormones, then that's not, it's not going to make a huge difference there. There are different types of HRT, as you may know. There's biologically identical HRTs versus synthetic HRTs. In the last 10, 20 years, we've really moved away from using a lot synthetic HRT, and we try to use it as little as possible, because we know that biological hormones have the beneficial effects of reducing heart disease and risk of stroke and blood pressure, etc. And of course, under the umbrella of biologically identical, you can have them, manufactured at specific dosages that is available, but you can also have them specifically made for you at a dose that you can tolerate, and that's called compounded bioidentical hormone. That is an unlicensed medication, but inevitably that's a choice that is there. And for women who've had a hysterectomy, so they don't have a uterus, they may just be on estrogen only HRT. But again, even in these circumstances, if you know that you have a risk of or genetic predisposition to heart disease, it is a good idea to consider balancing it out with the other female hormones, and not just to be on a single hormone replacement. And of course, women with a uterus are inevitably on that combined HRT, which is estrogen and progesterone. And again, testosterone is a very important hormone, and it needs to be checked and replaced if it's deficient. We also have a number of different routes of administration for when it comes to HRT. You can have it transdermally, which is across your skin, via a patch, a gel, cream, spray, or you can ingest it orally. Ingestion of oral estrogen can increase the risk of blood clot, because it can sort of affect the clotting cascade in the liver. But when you take it transdermally as a gel or a patch or spray, that can't happen. So if you've been told that you can't take HRT because it can put you at risk of heart disease or stroke, because it increases your risk of blood clot, that's not true for all HRTs. You just have to be, under care of a healthcare provider that can understand which type and also which route of administration works for you. Now, of course, HRT is one part, and the other very important part is our lifestyle, what we do from, our diet, nutrition, exercise. Then one of the things that we've all sort of heard that is really good for us is this, the omegas, basically. But there's so many different numbers, 3, 6, 9, 7. I'm sure you can walk into any health food store or pharmacy and you see a variety of this. And the reason why I've put this here is because omega-3 is the only essential fatty acid that we need. Essential, it means that our body cannot make it, and therefore we need to either get it from food or we need to take a supplement. And the food that is rich in omega-3, which is really helpful for the health of our heart, is the fatty fish. So it's either salmon, mackerel, the sardines. Any fatty fish is rich in omega-3, the seeds and walnuts and some nuts, etc. Of course, eating a Mediterranean style diet, we know, is very important for both our heart and for our gut health, to improve the good bacteria, to improve, because we know, again, gut health is really important when it comes to processing these hormones, especially when we're established on HRT. So it's great to once you've been established on HRT and you're getting the benefits from it, but on the other side, we have to be careful that we're not accumulating hormones and we're able to process out of our system. Reducing processed food, salt and added sugar is also really important. And making sure that we are, we have enough vitamin D, magnesium, and again, going back to omega-3. Omega-6 and 9 also are good omegas for when it comes to heart health. Omega-6 is it's a little bit, you have to be careful, because if you take too much of it, omega-6 is also available in processed food, so it has to be balanced out with omega-3, so you shouldn't be taking omega-6 on its own. And so the ratio, the ideal ratio is 1 to 3, so omega-3 to 6 to be in a ratio of 1 to 3, but many Western diets, it's 1 to 15 really. Omega-6 is available in like sunflower oil, soybean oil, this type of oils. And omega-9, of course, supports our healthy cholesterol level. So it increases HDL and lowers our LDL. It also reduces inflammation and improves our blood sugar control. So I've put some examples of recommended brands here, just because I do get asked quite a lot about this during consultations about, what supplements. And again, when it comes to, we know that fish oil supplements are good for us, but there seems to be a little bit of a confusion as to where to get it from, and how about if I'm vegetarian, how about if I don't want to take fish oil, all of that. So that's why I've put this on this slide, a few examples. Omega-3 is the one that is high in EPA and DHA, which is just the acids that is in it, which helps to lower triglycerides, reduce inflammation, and support function, both heart function, brain function, etc. And of course, a good alternative to fish oil is krill oil, and it comes in a form, phospholipid form, that is actually easier to absorb. And for those who are vegans, vegetarians, they can take a plant-based omega-3 supplement. Exercise and movement, there's when it comes to menopause and heart health, it's two sides. One is the aerobics and cardiovascular, increasing the heart rate, and the other one is strength training. So we are aiming to reach 150 minutes per week of moderate exercise, and we really need to find something that works for you, whether it's cycling, swimming, or brisk walking, or anything else that sort of you can maintain long term. But strength training, improving our muscle strength, and it's a real improvement in how much calories we can burn, in the support of our skeletal structure, in reducing risk of osteoporosis, as well as improving our heart health. And yoga, Pilates, stretch, any form of stretching that improves flexibility, it can have an impact on our cortisol or stress hormone, reduce it, which in part, it starts reducing the belly fat. It improves our sugar control when the cortisol comes down, and of course the all-important sleep. It improves our sleep. And very well, coming to stress and sleep, we know that chronic stress increases heart disease risk. There's a lot of research on this, and it's shown that if you're not getting enough sleep, which is really about 7-9 hours of quality sleep a night, and if your cortisol level is deranged, in that we usually wake up with a high cortisol level, and it goes through a very smooth drop throughout the day to very low just before bedtime to help us rest. And if we're not able to reach that, it really has an impact on kickstarting inflammation, again, the start of any chronic disease. So some techniques to improve our sleep and reduce our stress levels are meditation, deep breathing, and journaling. Journaling, it can be, because we often, especially with menopause, especially where we are in our life when we reach this stage in life, we can wake up really worried about, what we need to be doing, what's going on in the following day, or trying to process everything that has happened the day before. So it's whatever that works for you. Writing out, just, taking 10-20 minutes before going to bed with a herbal tea, just sitting there, writing down with a dim light, just what it is that you need to prioritize in your next day, or just emptying all the worries that you have in your head. It really helps, and they've done quite a bit of research on this part as well to show that the effect of it on reduction in cortisol level, reducing, of course, caffeine, alcohol, and screen time, especially before bedtime. And we want to prevent. We don't want to even reach the point that we're treating heart disease, but we want to prevent it from happening. And of course, knowledge is power. So I've put some numbers here to help you understand. A good high blood pressure is basically diagnosed with a systolic of 140 or above. That's the upper number, and diastolic of 90 or above. But for when we're talking about optimization of blood pressure, we want it to be no more than 120/80. And you should be checking this every, at least twice a year to make sure, because there's no symptoms for high blood pressure. Unfortunately, the first symptom is either a stroke or a heart problem. And checking our LDL, HDL, and triglyceride, not just the total cholesterol, but the balance of these individual cholesterols to one another, measuring waist circumference as well as body mass index, which is not, it's a tool that we have, but I understand that, in some circumstances is not very helpful, especially for those who are very athletic and have a lot of muscle, which can be heavier. So they're very healthy and fit, but their BMI can be alarmingly high. And of course, regular checkups and screenings, like, if you know that you have a family history of atrial fibrillation or irregular heartbeat, is to have a ECG or tracing of your heart to make sure that that's in a good rhythm. And depending on where the problem is, to have a checkup, whether with your GP or a heart specialist. Just some final takeaway before we get to questions, because I know you've already sent in really good questions that I really like to go over, and there may be more questions live, I hope. But we can consider HRT if it's appropriate, because as I said, it can reduce our symptoms, but even in the absence of symptoms, it can improve the health of our vital organs like heart. Eating well, eating pure with good fats, less processed food helps, and moving, any kind of movement, whether it's it's whatever that suits your lifestyle and you desire, basically. Managing our stress and sleep. Sleep is the time that you are repairing your body, so it's extremely important, and unfortunately it's one of the first symptoms of perimenopause. So women in their even late 30s, early 40s onwards often complain about sleep problems because of the hormonal changes that happens. Even in the absence of hot flashes and night sweats, they can have interrupted sleep, wake up or problem falling asleep. And of course, getting regular checkup, making sure everything is running smoothly. And I think that's about it. Yeah, we've come to question time. That's great. I haven't been keeping up with the, I don't know if there's anything in the, that has
Yes, Laila, I'll read those out now. Thank you. That was brilliant and really informative.
Great.
We've got a question here. What if you cannot take HRT due to previous breast cancer?
Sure. Yeah, that's a really good question. Of course, there are some breast cancers that are hormone receptor positive, and therefore is absolute contraindication for taking HRT. It really depends what the symptom. If you are considering some form of treatment for a particular symptoms, there are plenty of non-hormonal treatments that can help with hot flushes, that can help with sleep, with aches and pains. So it really, or if the issue is urinary symptoms. So if you're talking about symptoms, controlling symptoms of menopause, for people who are unable to take or choose not to take HRT, there are plenty of non-hormonal things that you can do. But if you're asking about how to help heart health, again, is by mainly lifestyle modifications that you can really improve just as much as taking some of the hormones.
Thank you, Laila. The same lady has commented, not all places in the UK will give testosterone on the NHS. So it does depend where you live.
That's true. Yeah. So I mean, up until even a few years ago, it was much rarer to get testosterone in NHS or even in the private. But now we understand how important it is in controlling some of the symptoms, and also has long-term health benefits. So and we do make testosterone from the ovaries and adrenal glands. So women, pre-menopause, they do have testosterone, and it does fall with menopause. So it is really important to replace it appropriately.
Thank you, Laila. The other question we have, are magnesium supplements safe with hypertension medication?
So very good. That's a really good question. So you need to, as you may know, there are many different varieties of magnesium supplements. So depending on the medication and what supplement and whether there is a deficiency. So you can still take it, but you have to just be careful that that you're on the correct one and the correct quantity.
Thank you. Is there a recommended time of the day to take magnesium? Is this better taking it at nighttime or first thing in the morning?
It really depends why you're taking magnesium. So majority of people that are magnesium, they're taking it to help their either sleep or restless leg syndrome, or they're taking it for muscle spasms. And in those circumstances, then it is preferable to take it near bedtime.
Can someone who's still having periods take Oestrogen 100 daily to help with moods caused by PMDD?
So yeah, I mean, for those of you, just a little bit of an explanation. PMDD is just premenstrual tension, but much more. And of some women have this because they have a deficiency in progesterone level. That can happen because usually with progesterone is released when you ovulate. So women who are not ovulating with every menstrual cycle, they're more at risk of developing this. And Oestrogen is a body identical, biologically identical progesterone. So the question is whether we should be adding that as a daily thing. For a person who is having a regular cycle, it's not advisable to take progesterone every day because that will make them have spotting and to have basically irregular cycles, because naturally progesterone is increased at the time or released at the time of ovulation. So you only have progesterone really for 2 weeks a month, and that sort of hormonal change needs to be imitated in someone who's still perimenopausal or even pre all of this but wants to take it. You can consider a different dose of natural progesterone, but that would be like the tailor-made compounded one, because the natural progesterone only comes at 100 milligrams and you can't really cut it. It's a capsule that you have to take as a whole. And so yeah, it's not advised to take it every day. There are other options, and it is a good choice for someone who can feel relief from their PMDD symptoms with progesterone.
Which type of magnesium would you recommend? Oxide, chelate, malate, taurate, as there are different types.
Yeah, there are many different, and it really depends on why you're taking it and what for. And so I wouldn't be able to tell you, like, it's not one type for everybody.
Thank you, Laila. My understanding is you should take magnesium on a night and also take vitamin D with K2 at lunch for magnesium to work fully. Is this correct?
It depends whether you have vitamin D deficiency or not. I mean, vitamin D with K is advisable because vitamin K helps to push D into the skeleton bones, so it sort of deposits it where it's required the most. But whether or not you should take vitamin D, because some women don't have vitamin D deficiency, and so they can just take magnesium without that. But if you have very specific supplement and vitamin questions, I really recommend somebody who is a expert in this. That would be a naturopath, or and we have a really good naturopath at OMC, Vera Martins, or you can just speak to if you go to Holland and Barrett or any of these big food stores that have the health food stores that have specialists that can guide you with that, because it is confusing. You're right, there are different varieties, as in combinations, and it really depends on whether there's a deficiency or you're just taking it as a addition to your food, or if there is if you have any GI problems that stops you from absorbing, and that's why you're taking it.
Thank you, Laila. How suitable would a candidate be for HRT if they have circulation issues? For example, hemosiderin issues, circulation issues.
As I said, there's different varieties of HRTs, and nowadays with the access to biologically identical and different modes of administration, like spray, patch, a lot of these conditions, we can now, you can have HRT even if you have a lot of the vascular problems. But you just have to be on the right dose of and the right route of administration. So it needs a little bit of thought and risk assessment, but it's not an absolute contraindication.
Am I putting myself at risk of heart disease if I do not take HRT during perimenopause?
I mean, as I tried to demonstrate during the webinar, there's certain things that happens with the fall in hormone levels. So, our cholesterol, our blood pressure does start to change with the fall in cholesterol. It really depends on other risk factors. It's usually not just one thing. So for someone who has family history of early onset heart disease, that's under the age of 70, for those who are current smokers, who are overweight, who don't do any exercise, who are very stressed, then of course you try to then eliminate or reduce the other risk by seeing if you can take HRT and the right ones, because that will start to at least reduce that risk. But if somebody is very, they don't have any of those risk factors and they have a very healthy lifestyle and they're exercising regularly and that, then and they don't have any family history, everyone is very different, that they just need to be assessed considering their own individual and family risk benefit to it.
Laila, it looks like we are done with the live questions, so I'll move to the questions that were submitted at the time of registering.
Sure.
Is HRT okay with high blood pressure and cholesterol?
Yes, so as I said, the correct type of HRT actually reduces your blood pressure and cholesterol, so yes.
Thank you. Should I be concerned about a small patent foramen oval potentially worsening during menopause, especially with factors like arteries thickening with age?
Patent foramen ovale, I think. Patent foramen ovale is that's basically a hole in the heart. It's a small hole between the right and left chambers of the heart that is present in all babies before they're born. And when we're born, at birth or immediately afterwards, that should close. But in some people, it stays open, and we call it a hole in the heart, essentially. And it doesn't usually cause any problems, and we don't need to step in and with any intervention and close it. It really depends on the size of it and whether or not it's giving any symptoms. But one of the complications with it that can potentially occur in some people is stroke, because it can a blood clot can form and it can then shoot up to the brain from the heart. And of course, with menopause, we just explained that menopause also increases the risk of stroke because of high blood pressure, because of high cholesterol, bad LDL, because of inflammation, increased risk of inflammation. So it may be a good idea for someone who has patent foramen ovale or hole in the heart to then talk to a healthcare provider to see what their risk is and what the risk-benefit ratio is, and whether or not they should be started on HRT.
Thank you, Laila. Does starting HRT 7 years into menopause still help reduce the risk of heart disease, and can it reverse existing heart problems?
So there is a sort of a golden window of opportunity to step in and reduce the risk of heart disease when it comes to menopause, and that's before usually it's before reaching the menopause and within the first few years of menopause. It really depends on what the heart disease is. Is it heart rate that is the problem? Is it the vessels that is the problem? Is it the actual muscle? And whether or not they're on any other medication. In some circumstances, it can help with it. I don't know about reversing it 7-10 years after menopause. I'm not sure about that.
Thank you, Laila. I'm already being treated for high blood pressure. Are there practical steps I should take now, considering menopause's impact on cardiovascular health?
So they already have high blood pressure and they want to know what steps to take to improve it.
Yeah, I'm already being treated for high blood pressure.
Yeah, so for people who are being treated for high blood pressure, of course you can, the best thing to do is to look at your lifestyle and start making those lifestyle modifications to reduce your risk of developing heart disease, even though you may be. So just because you are on medication for blood pressure, that shouldn't stop you from, and you can actually reduce the risk of morbidity and mortality by engaging in a healthy lifestyle. But also you can consider HRT if you're not already on it. But again, it needs to really, I think the important message that I like to give is that it needs to be the right type of HRT, the right dose of HRT, and that individual needs to be risk assessed for it to see whether they're, they benefit from it.
HRT is not an option for me due to breast cancer. I am on tamoxifen. Can you recommend alternatives for menopausal symptoms?
That's quite similar to a live question. I mean, tamoxifen is estrogen receptor. It blocks the estrogen receptor. So I assume this lady must have had estrogen receptor positive breast cancer, in which case HRT is, we can't really use it. But as I explained, there are many other treatments, non-hormonal treatments for, it really depends what symptom is worse and what symptom we are treating. So, for hot flushes, night sweats, yes, there's non-hormonal treatment for that. For aches and pains, for insomnia, urinary urgency, frequency, things like that, yes. For dryness, but so it really depends what symptoms we're treating.
Thank you, Laila. And we have one more question. If you are coping with symptoms of menopause, do you still recommend HRT?
I think that's a really good question. So you don't have any symptoms, you're coping with your menopause journey, but you want to know should I start on HRT? I have a number of patients actually like that they came to see me because not because they had any symptoms. They actually said, I sailed through my menopause, or I don't have any symptoms, but they know they have genetic predisposition to certain diseases. So it really, again, goes back to, I need to get more history from this individual to see, can they benefit long-term from HRT? And of course, it's, if you have to see, is there any family history of autoimmune diseases, thyroid disease, osteoporosis, and heart and dementia, and a couple of other ones to see whether you would benefit from it. So yes, some women take HRT not because of symptom management, but because of reducing risk of future disease.
Thank you, Laila. We still have some time, so if anyone has any questions, you can unmute yourself, or you can pop them in the chat box and I'll read it out.
Okay. Yeah.
We've got a question. How long can you stay on HRT?
It depends what type of HRT you're on. So the synthetic or artificial hormones, the recommendation is once you've reached the age of 60, or if you've been on it for 10 years. But with the biologically identical ones, there is no limit to it, as long as you're being monitored and you're following the screening schedule as well, with mammogram, smear tests, etc. There you can stay on it for life.
Thank you, Laila. We don't have any questions the moment.
Yeah, it is a really I really enjoyed putting this a cafe together, because I think it's not always that we consider HRT and or see the impact of menopause on chronic disease, and a chronic disease that is so prevalent, so important as heart health. So I'm really glad that we had this opportunity to spend some time going through it. And I think once you're aware and you know what impact you're in control of, and you can improve that health generally. Yeah.
Yeah, Laila, we are receiving really good feedback. Many are finding this topic very informative and brilliant. And yeah, I think we have come to an end now. Thank you, Dr. Laila, again. And yeah, thank you everyone for attending.
Yeah, thank you everyone. Have a good afternoon. Bye-bye.
Thank you. Bye-bye.
Bye.
Thank you. Bye.
Thank you so much.